everybody, I'm Rani Singh. I'm a pediatric neurologist and epilepsy specialist here in town at Charlotte at Levine Children's, and I was asked to speak to you all about what I know about seizures and epilepsy, and specifically with your child's condition. So before we start, I want to take a show of hands. It's totally up to you if you want to raise your hand or not. How many of us are girls, parents of girls? Okay, and how many of us are boys? Okay, so maybe a little bit more girls than boys. How many of our children are less than 10 years of age? And how many of them are more? Okay, so pretty evenly, pretty even. Let me go, I do have a couple of disclosures. So I work with some pharmaceutical companies on their advisory boards. I have some research clinical trials, and I serve here and volunteer with our Epilepsy Foundation board here in Western North Carolina. I will probably be discussing some off-label medications and devices, because that's just the world of pediatrics. Things always get approved for adults before they ever become approved for kids or even younger kids. So what I wanted to talk to you about is seizures and epilepsy, particularly with relation to 1P36, different seizure types and how to recognize them, where we are today in 2022 in terms of medication options, being sure and focusing on seizure safety and emergency plans if you need them, and some special situations that I was asked to talk about. Okay, so who knows what a seizure is? You tell me, what's a seizure? Sure, so a seizure, anybody can have a seizure. So the way I think of it is that your brain is always firing with neurons and the outer layer of the brain, and it happens when we're asleep, when we're awake. And what happens with the seizure is that activity gets a little too excited and it can manifest itself in different ways. So what's the difference between a seizure and epilepsy? Does anybody know the difference? Because they're used really interchangeably and it can get really confusing. So I wanted to kind of clarify. Yes, ma'am? Yeah, so exactly. The epilepsy means the tendency to have recurrent seizures. So, practicing now for more than a dozen years, still within the public, the word seizure, neither of them sound really great, hands down, but the word seizure sometimes just doesn't sound as scary as the word epilepsy. So I kind of want to explain. So when, someone hears the word epilepsy, what does that mean? Do I know anybody who has it? What does it look like? Are seizures the same, different? This is all things that can, come to someone's mind, and there's just so much that we don't know. So pretty much a seizure is a single isolated event, but every brain, 1P36 or not, has a chance of having a seizure, and that's important to know. And the way I would explain it to my patients is we call it epilepsy when we know that we're at risk for having recurrent seizures, and it's time to discuss a medicine to prevent it. So that's kind of the way I think of it. And still, a lot of people will say, oh my gosh, I don't want to use that word, but it is what it is, so we just kind of have to call it like it is. So epilepsy is super common. We used to think, when I got out of training, we used to think that it was 1 in about 100, people. That's also kind of the incidence, or what we call prevalence of autism, about 1 in 100. But now we're realizing that epilepsy is much more common, 1 in 26. I think it's just increased awareness, and so the way I kind of talk about with my patients and parents is say, if you have a classroom of kids with 20, maybe 25, not a smaller kind of special needs classroom, but your standard kind of classroom, on average about one child in every class is going to have epilepsy. They may not say it, they may not know it, of course it's their personal information, but that's how common it is. And so, again, I'm here in North Carolina. Our state population is about 10 million people, and if you take 1 in 26, I think I had to calculate on my calculator, about 300,000 people have epilepsy, so that's all ages. So a lot more common than you think, and that's what I get when I, whatever cause, talk about it, but then parents will start to, families of, with newly diagnosed, children with newly diagnosed seizures or epilepsy, then they'll come back and they'll be like, I found it was in my maybe in my family, maybe or not, a friend, or, people start talking about it. That's what we need to do. We just need to talk. So there have been, over the last handful of years, some articles in the medical literature that have talked about 1p36 in epilepsy, okay? And so this is what we know. We know that, here's another show of hands. So how many of you can count on one hand or less how many specialists your child has seen? How many of you can count on two hands how many specialists your child has seen? So most of us are probably at two hand, and there may be situations where it's TNTC, as I say, too numerous to count. So neuro is just one of the specialists and one of the doctors that your child has seen, a neurologist or even maybe a seizure specialist, but we know there are lots of things, hearing Dr. Scott's great presentation earlier this morning, that there are lots of other systems that can be involved. There was a paper that came out, and that's what I'll talk about now, that looked at about 30 to 35 different studies in kids with 1p36, and they found that seizures or epilepsy affected more than half. So 60% was kind of their average, but the range was broad, between 50 to 80%. And so they've also found that they were more often in females than males, and a lot of them start early in age. So you don't have to hold your hands up if you don't want to, but how many of you have your child who's on a seizure medicine? Okay. And how many of you have a child who's on more than 2 seizure medicines? So there was another study that came up more recently, and they looked at, and this was out of kind of all over Italy, and they found that majority of the kids who had 1p36, if they were going to have seizures, it was in the first 3 years of life, even in infancy. And infantile spasms is a seizure type that many children can have, and I'll talk about that because the treatment for that is different, regardless of the cause. But we are kind of becoming more aware, and I think there are situations where someone may have the special seizure type, the infantile spasms, and then undergo a workup like an MRI of the brain, a microarray, or even genetic testing to find out the cause, and that's how someone can potentially be diagnosed with 1p36. So how are seizures classified now? They're different than they were about a decade ago, and this has to do with medical international classification, and it helps to guide us to know what kind of seizure someone may have, helps to guide what kind of treatments and what we need to do. So as of about 5 years ago, there was new terminology, and we classify seizures into 3 categories. So focal, generalized, or I don't know. So focal has replaced the older terminology of what we call partial onset seizures. So these are seizures meaning that they start from one area of the brain, and they can stay there or they can spread. There are 2 categories. The old school term used to be simple partial. Now we call that focal aware, meaning you can have a little jerk and you know it's happening and then it stops. And then there are focal unaware, which means that you have loss of awareness or some alteration in consciousness where you're kind of a little spacey, or it could be, mild, or it could be, more pronounced. And sometimes focal seizures can go on to become generalized seizures where they spread to both sides of the brain. They kind of march, they have normal activity. I kind of think of it like a spark waiting to happen, and then it kind of can cause a flame or even almost like a fire, but not really. Of course, that's just a metaphor, so please don't take that literally. And then unknown means that no matter what we try to do or figure out, we don't know where the seizures are coming from. And I've learned to be humbled over the years that sometimes I just don't know. Even with a lot of the technology we have, we don't know. Sorry, this is a little bit faded, but first we try to figure out what type of seizure your child has, and sometimes it can be multiple, and we know that with 1p36 seizures can manifest themselves differently, and you can have different types of seizures. And then we try to see if we can classify the seizure, based on seizure types, what type of epilepsy syndrome or kind of distinct nature, type of epilepsy we have. Sometimes we can find that, sometimes we cannot. And then trying to find the cause. So that's kind of how the terminology has changed about over the 5 years ago. So like I said, seizures can, depending on the type, they can be different types of seizures. You can sometimes just stare. You can sometimes stare and your eyes go to one side. You can sometimes have a twitch or a jerk. And then sometimes they can be really subtle. What we know going back to 1P36 is that kids can have, not all of your children are the same, of course. Not all of your children's seizures are the same. Sometimes we can have tonic seizures where you stiffen. Sometimes your typical kind of grand mal seizures, of course, the scariest, where you start off with a tonic, you stiffen, and then you'll jerk into a clonic. Or sometimes you can have clonic. And like I said, that one of those studies said that 1/3 of infants with 1P36 that they've looked at have seizures in infancy can have those infantile spasms. So ways to try to figure out if it's a seizure or not, what type of seizure. I'll kind of tell you how I go about things, and still sometimes I don't know. So staring spells. Staring spells could be seizures or could not be, and that's what's tricky. So the categories of staring spells that are seizures, so the first category is what we call absence, spelled absence, but absence seizures, okay? There are kind of two categories of those, and I think 1P36 the kids I've seen usually don't have your typical absence seizures. Your typical absence seizures are going to be preschool to school age, where they can have them initially a little here or there, but over time they can have them multiple times per day, where they just stop what they're doing, stare straight ahead, may kind of have a blinking or like a little bit of a tremble, and they go back what they're doing. So starts, happens, doesn't, and then stops, and can just be, sometimes I've seen them, they're like 3 seconds, you blink, they're gone. Sometimes, a lot of kids can sometimes have them 20, 30 seconds, and they can have multiple times per day. They have, that's what we call your childhood absence epilepsy, which I don't think kids with 1P36, I haven't seen too many with those, and the absence seizures have a typical EEG. But what I've seen with kids like 1P36 and similar genetic conditions where you can have different seizures is sometimes what we call an atypical absence. So you're like, Dr. Singh, what in the world is that? So that's kind of like the absence, but a little different. It's kind of like a different version of it, where you can stare, you can zone out, you can have some jerking and twitching, and sometimes they can last longer than 20 or 30 seconds. And sometimes you can be tired afterwards, but they don't happen as frequent. And sometimes we don't know until we get that EEG test, and sometimes that helps us, sometimes it doesn't. But those are kind of the types of seizures that you can have, and we've seen that sometimes in kids that have genetic conditions like 1P36 or other chromosomal conditions. Their EEGs are a little different in what they call something called a slow spike and wave, and this is an example of an EEG where there's like 1 second separated, so I think this is about 10 seconds, and when they have the EEG on when the event's occurring. So those are kind of what we call the different categories of absence seizures, but then there are focal partial seizures, or the ones I was telling you about, focal with loss of awareness. And those are different. Those are usually not as often, can happen once per week, maybe a couple of times a week. Goal, of course, with seizure medicine is to stop those, so I'll get to that. And those, sometimes people can tell you that they have a warning, and I think with your child that may have cognitive impairment, of course your child's not going to be able to tell you, I feel something, but you know your child the best. You know when something's off, and there could be maybe an aura or a warning that something's going to happen. And then it can be a jerking of one side, a trembling. Those are the ones where you may have eyes or head turned to one side and then they come back. And usually those last longer. They can last a minute or two, and then you're tired afterwards. And a lot of times parents will tell me, then Johnny just goes and falls asleep and takes a big nap, which is not typical. So trying to figure out, this is what we try to figure out as your neurologist, to try to figure out what type of seizure it is, on how we can treat, and what type, because it helps us decide what type of medicine. So a little bit of infantile spasms. Does anybody know about infantile spasms? Or have heard about it? Maybe your child had it. So these are the special kind of unique seizure type that babies can get, that we as neurologists kind of take, for us, it's an emergency, because we want to recognize it, we want to diagnose it, and we want to stop them. Infantile spasms are kind of near and dear to my heart, and so if I see somebody and somebody's worried about them, I take it very seriously. I get them into the hospital, I put them on an EEG to figure out if it is or not, so we can begin treatment immediately. Because the worry is that if these go on for weeks or months, you can have a regression in your child's development, which you don't want, and nobody wants, obviously, and so we want to treat them. And the thing to know about those is that treatment of infantile spasms is different from other anti-seizure medication treatments. So I'm sure most of your doctors have a protocol, and I've worked kind of nationally to help develop some guidelines where we'll try either actually a steroid or another type of special anti-seizure medicine to try to stop those, kind of something that like a protocol that'll be a special treatment for a month, maybe longer, and then weaning off. But those are, important to know. They can occur what we call in clusters, as falling asleep or waking up. And we say infantile, so meaning infancy, but really the range is anywhere from about 2 months to even up to 2 years. As falling asleep or waking up with what we call clusters, so repetitive, it could be arms out, it can be one side, almost like a crunching, and actually the baby gets really upset because the baby's scared. So whenever I'm not sure if it's something, I always have pediatricians, they videotape it. There's a lot of technology out there. One thing we like cell phones for is to videotape, things, so that can help guide us too. And then I talked a little bit about the convulsive seizures, meaning the motor seizures, so muscle jerks, which is what we call myoclonic, usually of a limb. Tonic means stiffening, clonic is the jerking, and then tonic-clonic is a mixture. And Epilepsy Foundation has great resources, YouTube videos, and sometimes the tricky thing is that sometimes we don't know, especially in 1P36, if that odd movement or that odd behavior that's different, it's not typical for your child, if it's a seizure or not. So seizure always comes up as the possibility, but it is good to know there kind of be other seizure or epilepsy mimickers, and that's where it gets really confusing. We know that parents aren't always sure what's a seizure or not. We know nurses aren't always sure what's a seizure or not. We even know doctors and neurologists and epilepsy specialists, sometimes we don't know. So thankfully we have tests like EEG tests and things that we can try to figure out, but younger kids may get excited and sometimes hold their breath, and then have like a little bit of purplish, almost like, oh my gosh, my child is pale. And my son used to have big time breath holding spells where you almost like you can have what they call reflex anoxic seizures when you're younger. You hold your breath and you almost kind of stiffen. It's just because you're holding your breath. You can have spells where they look like you're kind of losing tone, but it could be almost similar to breath holding, and you kind of look like you're about to pass out. And then the movement disorders are a whole hodgepodge of different movements that look like seizures and may or may not. And we do run into that where as you're falling asleep, or stereotype movements, and there's a whole, that when I am not sure, again, that's why videos are helpful, and sometimes I reach out to my colleague who's a movement disorder specialist to try to help me figure out if it's a seizure or not. Startles in sleep, jerks in sleep, that can be really hard to tell too. So it can be very hard to tell what's a seizure or not. Okay, so seizure medication options. We'd have about 30 plus, maybe 40 anti-seizure medications, and you might see some on this list. This isn't comprehensive, but that your child is on. And the way your doctor picks out what type of medicine to use is several factors. So one, again, trying to figure out what type of seizure is that. Is it a focal or is it a generalized? Is it both? Is it, I don't know. Because there are two broad categories. On the left you can see are what we call narrow spectrum. So those are traditionally used more often for those focal or partial seizures, and they can sometimes make the generalized seizures worse. So that's something that we always try to kind of think about. Then you have a category, thankfully, where we still have a ton of safe medicine options on that right side, which are what we call broad spectrum. It means they work for all seizure types, so it's kind of like, all in one, is what you'd like, because you want your child on, you want your child to be on a medicine with minimal to no seizures and minimal to no side effects, right? That's what we all want. There are some newer medicines, and I have these kind of highlighted with the stars, that are indicated for certain seizure types. So the way that a medicine gets approved for seizures is that most of them have to get approved first, in clinical trials for focal or partial seizures. Then they can also get approved for that other category, the generalized seizures, but that's how things come about. Only up until recently, we in pediatrics had it even harder than we had. Things have gotten a little bit better, is that when a medication, adults always get everything approved first, right? So when a medicine was approved, they would approve an anti-seizure medicine only for ages 12 and up, okay? So at least half of us have children that are less than that age, and sometimes we would try, we knew it would work, but we couldn't get it approved because insurance would come back and say, no, it's not approved for 12 and up. And I still get that with some of these newer agents. Thankfully, the way they changed how you can get a medication, an anti-seizure medication approved, is a lot of times now they'll do what they call PK pharmacokinetic testing and data to give you the right dose to then, now instead of it getting approved 12 and up, it actually can get approved for ages 4 and up, which is great because that opens up a lot of options. And now what a lot of the companies know, because we see lots of kids with epilepsy, we really need to get it down to as safely, of course, as low of an age as we can, so some of these medicines, it's kind of a trickle down. They get approved for the adults, then the older kids, and then the younger. But sometimes it just doesn't feel like it's fast enough. So when we choose a medicine, I'm sure it seems like a majority of you have gone through this discussion with your neurologist before. You want something that is going to control your child's seizures with minimal side effects. And the problem is anything can cause side effects, and if your and I'm sure your doctor has told you, and it really is hard to predict how a child will react. So, any medicine can cause a rash. Any anti-seizure medicine that's working to kind of calm down that abnormal electrical activity can make you tired, can make you sleepy. It's also working on brain chemicals that can sometimes, affect mood. So sometimes your mood may be a little bit aggravated, sometimes your mood, and if you look at, it's kind of like watching the the NBC News where they have those medications for adults, and like they talk to your doctor, risks include ABC, XYZ, it's the same thing when you look at the label for an anti-seizure medicine. Some of them we don't want for females because they're a little bit more, stronger or affect bone health more so than for boys. So we take that into consideration. Some of them can cause increased appetite. Some of them can cause decreased appetite. So these are all the things that we go to try when you're sitting down with your doctors trying to talk and decide what's the best first option, what's the best second option, and then they work differently. So there are medicines that together work pretty awesome, have what we call a synergistic effect, and it's almost kind of adding a second medicine. Of course, you don't want to if you don't have to, but we know with 1P36, sometimes we need more than one medicine. Having two medicines that complement each other can be, kind of like I like to say, the icing on the cake for your child. This is an older list, med list from all the, the 30-something medicines, and of course, like look at the right column is, for each medicine's, potential side effects. Just knowing that there's side effects for everything. And then again, infantile spasms are their own category where we do either steroids or something called vigabatrin and as first line, and then other anti-seizure medication options as others. What's tricky with infantile spasms is that, depending on where you read, and it really has to do with if you can find the cause or not, more than 50, about 60% of kids, even if you get their spasms under control, can still go on to have other seizures down the road, so we definitely keep a close eye on them. So that's kind of the discussion of medications, but feel free to interrupt me as I'm talking or at the end about any questions that you might have. So then let's talk about seizure safety, emergency medicines and seizure action plans. So how many of you feel comfortable what to do when your child has a seizure? How many feel uncomfortable? There may be some. Okay, maybe people don't want to say it. That's okay. How many of your children have an emergency plan of what to do if we have a seizure that lasts too long? So not everybody. And that's something you can kind of go back to your doctor and talk about. So luckily, overall, if you take all seizures, all epilepsy, thank goodness, most of them stop within about 5 minutes. Depending on where you read, 95% stop about 5 minutes. And the way we've developed, not really me, but my predecessors, and those in the world of epilepsy drug development have looked at trials. In the past, they looked at giving an emergency medicine, I'm talking like 20, 30 years ago, if a seizure lasted 20 minutes or 30 minutes. But now the recommendation is that if a seizure keeps going on nonstop for at least about 5 minutes, you're worried that it may not stop. That's when you should think about an emergency medicine. Because then you have other situations where you can go into status epilepticus, which is recurrent seizure activity. You don't want that to happen. That means we come into the ER, we have to be hospitalized. Our goal is to keep you home safe and have a plan, but also know when, if your child is sick and that's causing more seizures, when to get the right treatment. So there are kind of two forms of status epilepticus, which really means having recurrent seizures that won't stop with whatever you have at home, and you need to, get to the ER, you might need to be hospitalized. And the two categories are convulsive or non-convulsive. Convulsive are more easy to see because you're having full-blown jerking, and you have to stop that, because if we don't stop that, we can run into respiratory problems, and we have to do everything we can stop that. The harder one is non-convulsive, where you don't know if the seizure's over with, and that's the tricky part. You give rescue medicine, you're at home. I gave my diazepam, rectal diazepam, but my child's still a little tired, still a little twitchy, and you don't know, and sometimes we don't know as the doctors, and even the ER doctors don't even know. You're like, great, Dr. Singh, you're telling us a lot about what you don't know, and so those are ones that can be harder, where you might need to be, come in, get admitted, be placed on an EEG to make sure we've stopped the seizures. Have you been hospitalized for seizure activity that won't stop? Yeah. So a lot of schools have seizure safety plans that they want you to follow. How many of you of your children are of school age and attend a school? Great, awesome. So your school nurse will want to know, say, go back to your neurologist. We need to know ABC, XYZ, what to do. And what I try to do with my kids who are at risk for having seizures that won't stop at home is have a plan for home, a plan for the emergency room, which is really up to the emergency room to decide if they're going to follow it. It's more like a suggested plan, and even like a plan if we have to be admitted, who to call, and all that. So the important thing is knowing everybody. If you have any family member who has epilepsy, you want to be familiar what to do, because you might be the only one with your child if your child has a big seizure. So knowing first aid, knowing how to get help. Epilepsy Foundation has lots of great resources online. Their website is kind of overwhelming because there's so much information there, but they're great resources for training for seizure first aid, especially with the convulsive ones, nothing in their mouth, on the side, counting it, though we know that seizures seem to last forever, even though they may not be as long as you think, and we know that parents, caregivers, nurses, doctors, even for us, we're not good at telling how long a seizure lasts. So trying to take it with time, and always feels like forever. And then this is an example of some seizure emergency plans, but you can definitely devise your own for home and for school. And it really should be catered to you, as you know, for your child and what works for you, and it changes. We know our child is growing. We know medicines are all based on age and weight. So, I mean, I have some kids that I come in like they're little wrestlers. Let's do a weight check to see where you are and see if we need to adjust our doses. Same thing with emergency medicines, of every visit checking where are we, have we grown, have we lost weight, do we need to adjust this? So it's just because you have one plan today on Friday the 29th of July doesn't mean it could potentially change next week. So making sure you have your neurologist that's always kind of looking at these things and reevaluating these things. Just a pitch for the Epilepsy Foundation. Like I said, they have lots of resources online for seizure safety, first aid, school resources and all that. You can just Google it and you'll find it. And I wanted to talk a little bit about my top options for seizure emergencies, both for home and at school. And many of you may already know about this, but just kind of, hopefully I'll share some new information or make you feel better about, you know, what's going on. So any seizure, all the seizure emergency medications are in the family of benzodiazepines or benzos, and they work on stopping the seizures. You know, they work pretty much on a neurotransmitter called GABA, which they activate GABA to decrease that abnormal misfiring. So that's what they work. So most of your seizure emergency medicines are probably going to be in this category of benzodiazepines. And so PAM means a benzodiazepine. If it ends in PAM, it's a benzodiazepine. So Clonazepam, old school, been around for a while. I don't think this is good for a seizure that persists and won't stop, because this is enteric, meaning it's going to go through your child's gut, it has to be absorbed. But what's nice about it, and I'll use this in situations where kids have clusters of seizures. So, you know, Susie has a fever, she's having a little bit more of the seizures, but you don't want to give one of those big, you know, stronger medicines. Sometimes giving this in the setting of seizure clusters, we're sick, we're under the weather, you can give this a couple of times a day, up to 3 to 5 times a day, 3 to 5 days in a row, and kind of prevent, you know, while we're sick, kind of in those special situations. So I like Clonazepam. It's a tablet that you can put, if your child has a G-tube, can put through the G-tube, or it's a melt-away, but it's not like an injection or an intranasal. So that's definitely an option. And then we have the other options, which are more to stop a seizure if it's persisting. So how many of you know about the old school version of intranasal midazolam? It's also known as Versed. It's an anesthetic. This is a medicine that, thankfully, I'll talk about as in the form of a nasal spray, dosed already comes handy, but this, in kids who have maybe are at home or have home health nurses or a nurse at school, or even if you're at home, you could consider this option because the one that's available is technically ages 12 and up. So this, what this is you have to get it from your a special pharmacy, which may be nearby or may not. A lot of the commercial pharmacies won't have this, but it comes in a vial, and it's a 5 milligram per ml. And you get what we call an atomizer kit, which is like that, the syringe. And it's really a needleless syringe. It's going to be like a little plastic tip so you're not poking yourself. And you draw it up, and then you take the top off, and you put what we call an atomizer. So what it does is it makes the liquid go into a spray through the nose. A lot of schools don't like that because it's, way too many steps for an emergency, and I totally understand that, and it can leave room for error. But I have some families that'll have this for home as an option if they can't get the other nasal sprays approved because insurance or child is too young or child is too small as an option. So sometimes this is had gained popularity and then has kind of trickled down a little, but it's still an option, and I'll tell you why. I don't know if you heard recently, about 2 weeks ago, since COVID, we've run, I know at least I can speak with epilepsy, I don't know if you've run into that, there have been supply chain issues here and there with different seizure medicines, which has been a real pain and not cool. So as of 2 weeks ago, the more I've heard that the Rectal Diazepam is getting harder to find, and I think it's getting a little bit better. So how many of you know about Rectal Diazepam or Diastat? Yeah, so Diastat is, you know, for the younger age, about 20 pounds or maybe a year, some depending on how chunky your baby is, up to older age, and it's the diazepam. It's a rectal suppository. It comes pre-dosed. It's based on age and size, for the younger kids, I'd say up to age 6, this is probably still the best option. And their website has a lot of information, but that's why schools like it as opposed to that nasal one, is because this is a one and done. You're not going to be giving the wrong dose or anything like that. In the past 2 years, though, thankfully we have made progress with these nasal sprays. So the same as the midazolam, but comes already pre-dosed in a spray. So I'm sorry, I didn't bring any demos, but everything is on the websites and everything. So it comes in one dose, it's 5 milligrams. So that's technically supposed to be more of an adult size. So on label, meaning this is FDA approved for ages 12 and up. Sometimes insurance, depending on your child's weight and size and your insurance, which we always are fighting with as your neurologist, I promise you, may let you get it approved even at a younger age. And they're great. They're like, I kind of think of them as like little Flonas's, but there's one dose in it. It's in the liquid is here. You open up, doesn't matter what nose, you just spray it, get it in, and you're good. So schools across the country are getting more comfortable with having this as an option. But there is also the diazepam nasal spray, which is available for ages 6 and up. So kind of the way I've changed my practice with these new options is if they're itty bitty, kind of up to 6, probably the Diastat is the best option. But then once we're going to school and we're in elementary school, we have the intranasal diazepam, and then maybe for our older kids, middle school, high school, we have the intranasal nasolam already dosed. So how I decide is based usually on age. And this is similar, the Valtoco brand name, the intranasal diazepam is similar to the Diastat in that it's based on your child's age and weight. So it's not like that other one, there are multiple different doses available. So that's what I'm going to talk about, emergency medicines, but then I was asked to talk about some special topics. So drug-resistant epilepsy. Have any of you heard that term before? Intractable, uncontrolled, refractory, DRE. So what does that really mean? So that means in our world that your child has tried at least 2 appropriate medicines for his or her seizures or types and is still having seizures. We see that, and it's kind of known to happen in 1P36, and we know that if we try more and more, I think the statistics are if you try a 3rd or 4th medicine, the chances of becoming seizure-free after trying a 3rd or 4th medicine are 10% or less. That has to do with epilepsy in general. So I do think if your child is still having seizures, make sure you get in touch with like a comprehensive epilepsy center that could discuss other options, not just medications. So what do I mean by that? Dietary therapies. How many of you know about the ketogenic diet? Has anybody tried the ketogenic diet? Yeah. How's your experience been? No? Yeah, it's not, everybody's different. Yeah, see, everybody's different. So just to review, the ketogenic diet has to be done with, under the care of usually an epilepsy specialist, along with a dietitian who specializes in the ketogenic diet. So just to give a high view, it's not like the dietary fads or anything. So not the same as what you see online. Oh my gosh, I lost a bunch of weight or anything like that. But it's a high-fat, adequate protein, low-carb diet that makes the body think that, almost like tricks the body that you're starving, though you're not, and makes your body change its energy sources. How it works, nobody knows, and if they tell you they know, it's all speculation, so just know that. We really don't know how it works. And that's definitely an option where the goal is to try to control the seizures better. People have seen that if it works, cognition, awareness, can help. But it has to be in the setting of, the right people to work with you. So I do the ketogenic diet together with my dietitian. She runs the show, really, and she works with the families. And it's one of those things, we try to give it a good try, but if it doesn't work, we're not going to keep you on it, like you mentioned. It just, some people it works, but definitely something to think about. And then we talk about surgical options. So do any of your children have any type of stimulator? Yeah. When you talk about epilepsy surgery, there are kind of two ways to think about it. So one is trying to find where that person's seizures come from. So mainly that's when you're talking about just the focal seizures, they're all coming from there, and is it a safe place to remove, okay? So myself as an epilepsy specialist, I take kids through that process. With 1P36, my understanding is that the seizures can change, and they can be a combination of the focal or the generalized. So a surgical resective option usually isn't the best option. But then we talk about what we call neurostimulation or neuromodulation, where the goal is to decrease this frequency and duration of seizures as an add-on to the medication, and then potentially cutting down medication. But it's hard to say. So I want to talk to you a little bit about that. So the vagus nerve stimulator is kind of the first. Anybody heard about VNS, vagus nerve stimulator? All right. So it's the first neuromodulation that's really come about for epilepsy, and it's been around now for about 25 years. It got approved in the late 90s. And the way I like to think about it is, like, how people have pacemakers for their heart, I think about it as a pacemaker for your brain. So, and that's exactly what it looks like if you look here. So what happens is there's a battery that's placed under the skin, and it's not a brain surgery. There's a lead that connects and sends impulses to the vagus nerve. The vagus nerve controls some swallowing and our voice. So the side effects sometimes are a little cough or hoarseness when someone first gets it. And what happens is a surgeon implants it either on the same day, or sometimes in kids like here, they'll usually watch you overnight if you get it implanted. And then really it's the neurologist that controls with an iPad, will control the settings, and you have 3 settings. So one is 24 hours a day, what we call the output current, that is 24 hours a day how it cycles. Then there's these newer ones have something called the heart rate detector, or I call it the heart rate detector. It's called an auto stim or tachycardia, that with what they had found in their studies, this company, is that 80% of seizures, when people have seizures, their heart rate will go up. So that's something that if your child's heart rate goes up by 20% or 50%, it can give a little extra boost of stimulation. Aside from the 24-hour cycling that it's doing. And then the third is that you have a magnet that can kind of get, when a seizure happens, that can stop this, that can decrease the frequency and duration. So again, this used to be only 18 or 12 and up, and thankfully we've got it approved for ages 4 and below. I have had, this is why my disclosures say off-label, I have had some kids younger than that who've had it done. And so the side effects that they've found is initially, because the vagus nerve controls your voice and stuff, is like a little bit of hoarseness or cough. And that can sometimes, we can thankfully, with my little programmer, I can change the settings if that becomes an issue. I have some kids who'll have it, and they'll like the sound of it because it makes their voice kind of, they'll sound like they'll talk and go, like they'll do it, make it, when it's going off, they'll feel it and make that sound come out because they like the way their sound talks. Like I said, they're now in the 7th generation, which is smallest, lightest, and kind of less invasive. And like I was saying, then you have a magnet to swipe if to stop when if your child has a seizure that is programmed usually to go off every. You can swipe it every minute, so that's definitely an option. Responsive neurostimulation is something that's newer, and it's usually for people who have focal seizures and they're not candidates for brain surgery. That is approved for ages 18 and up. The company is doing a clinical trial to bring down the age to 12. And as opposed to the VNS, which there's a stimulator in your chest, the RNS has a battery on the surface of the brain, and it detects seizures. That's what they call response. It's trying to detect the abnormal electrical activity really in the form of milliseconds before anybody is seeing it overtly, and then send the impulse just there to stop the seizures. I have several patients with this, and they're of all different ages, but usually those are situations where you know at least not more than 2 locations of where the seizures are coming from, and they're not good risk. They're not good candidates for a brain surgery because it could be affecting their memory area or their motor function. And then deep brain stimulation is coming about. Most people think about DBS, deep brain stimulation for movement disorders. So the most common neurologic condition that it's really used is the Parkinson's disease for tremors. But it is starting to be used in adults more than kids for epilepsy, and it's similar in that you have the generator on the chest, but it goes to the deeper parts of the brain called the thalami to try to, similarly to the VNS, to stop the seizures. It is, again, only FDA approved 18 and older, but there are many places and institutions that are doing this in pediatrics. So a little bit about cannabidiol. There are lots of over-the-counter forms, but just know there's only one form that is FDA approved. I can't believe it's actually been approved now for 4 years. Time has flown. It's called Epidiolex. It's a brand name only. And it's approved for 3 types of epilepsies. 2 are genetic conditions, Dravet syndrome and tuberous sclerosis. Different from 1P36, but some similarities they can have. And then the other is more of not like a genetic condition, but a seizure, like I was telling you about epilepsy types, Lennox-Gastaut syndrome, which I think kids with 1P36 can have, where you have different seizure types. You have staring, you can have drop seizures, you can have the tonic-clonics. Those are the 3 conditions that are FDA approved, but depending on insurance, some insurances may cover different types of epilepsies. It comes in an oil that's taken twice a day. The oil is sesame seed based, so you have to try to make sure you're not allergic to that, but that's the main medication, and it's natural, so it's not synthetic. So a little bit about hormones and epilepsy. It seems like we may have more girls here than boys, so I wanted to talk a little bit about that. Catamenial epilepsy is the medical term that we use that means that around the time of our period or at some point in our cycle, our seizures act up for whatever reason. Depending on where you read, when I train, and this is kind of what I'm more used to, about 20 to 30% of females with epilepsy can have a catamenial component. And I used to think it had to do with more when the cycle was about to start, like relative to fluctuations in certain female hormones. But really, it can be any time of the cycle, not just around the time that you think your child's period is about to start. And the thing about this is that your typical, all those different anti-seizure medicines, they don't really help if there is a big hormonal component, so we kind of have to look at other options if that is an issue. Clonazepam, like I was telling you, that can be used for clusters. That's been shown around the time that, like, say, the 3 to 5 to 7 days that you think your child may be having more seizures, you can give just around that time. Acetazolamide is a medicine that's used for most commonly for altitude sickness, but it's actually similar to a couple of the other anti-seizure medications we use, and has been shown during that week that seizures act up that may be helpful. So those are options that I've worked on some of my girls who have seizures that act up, when they hit puberty. The other is really just hormonal options. So connecting with a gynecologist who knows how seizures and seizure medicines affect hormones and all that. Thankfully here we have a specialist who I work very closely. When it comes to hormones in epilepsy, it's tricky because estrogen has pro-convulsant, meaning it's almost like seizure generating when you think about our two main female hormones, and progesterone has anti-seizure properties. So when we look at anything for hormonal, we're looking at more progesterone based and more progesterone and less estrogen. So just some takeaways. Seizures are common in 1p36. Many of you have been living with it now for some time. They can start off in infancy or even usually an early age, and they can take any type of form. So really the treatment is geared to your child's seizure type, and having a good seizure emergency plan for home and for school, knowing that if seizures persist, look at other options, be it dietary therapy or the neurostimulation. And of course all of us, you are the ones who decide the best quality of life for your child, and our goal as your neurologist is to support you in whatever you want, what your decisions are. And I have plenty of families say, I don't want to go to the ER, and I tell them, when seizures, I don't want you to either, but you kind of have to, when you're uncomfortable and you can't keep your child safe at home, so it's good to know that. But just let us, and please always let us know. You're a network of people. I always say, what are the other parents saying? What do they feel has been happening? You're a source of education for us too, as your neurologist. So please keep that dialogue open. And now I think it's time to eat lunch, but I'll be glad to take any questions, and I'll be here through the end of lunch if you all have any questions. I hope this was helpful.
Any questions?
I was just so full of information, huh? Excuse me.
So if anti-seizure medicines are just a suppressant, is it ever safe to really take them off? Or?
That's a great question, and every person, that's a dialogue and individualized for every person. Too much medicine is not good, and I think it depends on how your neurologist. We sometimes know less is better. I have had experiences where taking completely off is not. If I have a parent who's worried about side effects, I like to prefer to transition it. And again, it depends on that child's seizure burden, but a lot of times my understanding is 1p36, if your child does have seizures, that you will be looking at long-term anti-seizure medication therapy. Coming off, even no matter how slow you go, sometimes you can have breakthrough seizures as you're coming off. And it really becomes, it's a safety thing, but trying to find that balance between side effects too, and optimizing, development, quality of life, cognition. It's definitely a dialogue to continue to have. But my understanding and my experience in my patient, the kids I've taken care of with 1p36 and similar, is that I really get nervous coming off medicine, and I'm kind of conservative and pretty wimpy like that, because I don't want you to be stuck in a situation where your child has a long seizure or you're in somewhere where you can't get the care that you need.
I also have another question. When do you transition from treating infantile spasms to, transitioning to an anti-seizure medicine?
That's a great question. It usually depends on each individual person, child and baby. So What we know from infantile spasms is that the top line medications are a form of steroids, either oral, prednisone or some form, or the injectable ACTH. The literature keeps shifting. For the most part, they're about the same in terms of effectiveness. A few years ago, there was some literature that said ACTH may have a little bit better edge than prednisone, but now it's kind of shifting that they really are equal. Or vigabatrin, which is a daily anti-seizure medicine. And so usually what most people will do is start with either of those. And if and you want to get the spasms to stop, some institutions, and depending on your insurance, may do both a steroid and the vigabatrin together. We worry about infantile spasms going to another seizure type kind of in that honeymoon period, maybe when the spasms are under control. So kind of between 1 to 2 years of age. So a lot of people, and it's, well, let's go through some scenarios. So whatever treatment we did, first line, second line, one of those treatments worked, the spasms went away. But our EEG still shows we're at risk for seizures, okay? And then so we're talking a little bit maybe more about 1p36. We know that seizures can still happen. Most will probably, and what I would do is probably transition off one of those spasm medications to a different anti-seizure medicine, maybe kind of in that broad anti-seizure category that could prevent any type of seizure. And also there are some that can also prevent the spasms from coming back. That's one way to look at it. So you're still talking about being on an anti-seizure medicine, or the other option is that you wean everything off and then you kind of wait and see. So a lot of that has to do with dialogue, between I have a helper here, the dialogue between the provider and the parents. But it really is, everything is, just like Dr. Scott said, every child's different, 1p36, everybody's different, and I can definitely tell you the seizure, everything is geared towards, each individual and how that person's doing. You're supposed to come up here and help me, kiddo. Any other questions?
Yeah, one more over here.
Sure.
Hi.
Hey.
So our kiddo is 14, so for many...
Hello.
She's like, that's me. So for many years she's used Diastat and it's worked, it's worked 90% of the time. We've had to go to, the ER to get something else. Recently she was switched to Valtoco. Just wondering thoughts and words of reassurance. We've never used it before, and I don't know how many people are in that place where they're switching emergency meds, and everybody says they're the same, but I'm wondering in your practice if you've seen that it is just as effective, or any kind of words of encouragement.
I think everybody's different. The ease of administration is huge. If you're at the mall or at the park, and you find that she starts to have a seizure, you can immediately grab it out of your purse or her backpack, spray it. You don't have to, worry about, in terms of, no, we don't have to worry about, we shouldn't have to worry about modesty, anyways. Most of my patients have found that I've transitioned, have found it has worked well. I can think of a couple, not 1p36, just epilepsy in general, and these are parents of big teenage children who still feel that Diastat didn't, the Valtoco didn't work as well as Diastat. I've had some parents that get nervous about, am I sure I got it all out there, because the way it is you will feel, you pop it, you will feel a pop, and you'll know that the medicine's out, but it's just transitioning from what you're comfortable with and out of your comfort zone, I think, is the biggest thing. So I've had some that said, oh my gosh, it didn't work, but I don't know if I, administered all. So in our clinic, we always go through teaching and have some demos and all that. So make sure you feel comfortable. But for the most part, everybody that with little exceptions that come to my mind, most people have tolerated it okay.